Good morning, everyone. I'm Dr. Priya Mathew, Fellow in Pediatric Oncosurgery at SGPGI Lucknow. So we have a 3-year-old girl who presented with low-grade intermittent fever for 10 days, mass in right upper abdomen associated with mild pain for 7 days. So she was symptomatically managed and evaluated in a private hospital. A CECT abdomen was done, which revealed a large heterogeneous right renal mass with IVC extension up to the right atrium. She was then referred to SGPGI. Here in SGPGI, she was afebrile, hemodynamically stable. On palpation, there was a 10 by 10 centimeter abdominal mass, predominantly in the right lumbar region, with extensions to the surrounding region. Her labs were within normal limits, except for serum LDH, which was around 724. So ultrasound was done, followed by CECT abdomen. On coronal and axial view, as you can see, there was a large heterogeneously enhancing solid mass measuring around 10 into 10, 10 into 8.5 by 6 centimeters, which was extending into the renal pelvis. Laterally, it was infiltrating the perirenal fascia with vascular extension into the RRV, proximal LRV, the IVC up to the right atrium. So then the metastatic workup came out negative. We went ahead with USG-guided TrueCut biopsy, which revealed a triphasic Wilms tumor. So my question is, what should be the next line of treatment in such a scenario?
Can I ask the board why biopsy is required for such a case? But they had gone ahead and done a biopsy. So is biopsy actually required in this case?
Yes. A few questions before. Is that thrombus floating in the right atrium or not? Is the blood flow feedback to the heart correct?
It was not free-floating. It was stuck to the right atrial wall. And the blood flow was correct to the heart.
Yeah, because it depends on those factors, whether you go in emergency with cardio-surgical team or not. If there is no floating thrombus in the atrium, there is a risk of the big pulmonary embolism is limited. And then you should start with preoperative chemotherapy, just the standard way, actinomycin, vincristine, and you assess the patient. We are doing that weekly. With the ultrasound, but the main assessment is after 4 weeks, of course.
So as sir suggested, NACT was done. So in this particular case, the chemotherapy regimen and the duration of NACT before re-evaluation. That is the next question.
There was a big number extending up to right and it involves right. What's the question is that TrueCut biopsy is really needed in this case?
We wouldn't do that. This is a typical age, typical localization, and typical form of Wilms tumor with thrombus. But it is never a mistake. It is never a mistake. You had the right to do that.
It doesn't occur. So, though I do biopsy in every patient, but for something like this, I may avoid it.
No, sir. I have operated. There was a big mass that looks rising from upper colon for right and involving the liver. Middle hepatic vein, there was thrombus, and right hepatic vein was there was thrombus. And it actually, I think it was retroperitoneum involving that role of kidney, liver, and tumor extending up to real liver cancer. And alpha fetoprotein was highly rare in 6,000. We have going to show in and it was came out, sir. Initially, I thought it was a Wilms tumor, then we, after tumor marker, we thought it is a hepatoblastoma, then fluke and biopsy. We had given 2 cycle of Wilms tumor, which took fluke and biopsy scores from renal tissue. So we give 2 cycle of chemotherapy, radiotherapy, that not responded. We again went back to the biopsy, then our radiologists, they are very clear. They show if there is IgG thrombus, there is hepatic thrombus, and it's going to up to atria, but there is no thrombus in renal. So that was very difficult. We started therapy for germ cell, and we tremendous result. More than 60% reduction. They all has gone thrombus. So that's why we have gone for COVID vaccine.
So my opinion is when we don't have tumor markers like WIMS tumor, non-WIMS renal tumors don't have tumor markers for no, corroborative diagnosis for as a diagnostic marker, we must have a biopsy. That's what my opinion is.
No, but I don't agree with it. The world literature very clearly shows that for classical age, classical radiological features, and classical feature like IVC thrombus, we have to assume it's Wilms tumor. And a biopsy is done only when there is no response. With the first 4 weeks, as Jan mentioned, for first 4 weeks or 6 weeks of chemotherapy, if it is not showing a response, then you do a biopsy. And for a typical renal tumor with IVC thrombus, I won't even do an alpha fetoprotein because it's not there. So, I mean, because we have seen, at least in our center, we have seen patients die because of hemorrhage, because of biopsy. And unfortunately, when these are done, and then they come in the night, the patient is bleeding, do something, it's very difficult to do anything at that point of time. So for one odd case we get in our, whole series of patients over years, we cannot justify saying that we should advise biopsy for all the patients. So I think the message should be very clear that if somebody is doing this, okay. But as a teaching point, we do not need biopsy for typical renal tumors. And the only thing that the UK group said that they are doing 6 core biopsies is because they wanted tissue upfront for biological studies. In India, if we are not doing biological studies, then why do we need a biopsy for?
One thing which again, I do really biopsy all the time. And in the world literature, even the umbrella protocol includes that whenever they do it, of course, they have got indications that mentioned yesterday. The complication rate is only 1.6%. And if you really go into the literature, I mean, I haven't heard this before, but no death is reported. There are 2 track differences are mentioned, but in both the cases, I mean, I went to look at those 2 papers. They were both done transperitoneally and not through the retroperitoneal route. So, I mean, I don't think.
I think we should first answer the first question.
So
Is it required?
The question is located in a different place. Once you do TrueCut, you wait the results about a week, because this is regular histology. Once you decide that you have a diagnosis, you start right now with chemotherapy. So we gain a week time.
So we will use about, I mean, our center about 5-7 days, sure. Waiting for the biopsy report.
But Dr. Yogesh, I think what Jan has pointed out is very important, the time duration. In a busy institutional practice like in AIMS, we would get a 2 or 3 weeks date for the biopsy. This biopsy actually should safely be done under GA. So you are going to wait for that 3 or 4 weeks and then another week for the biopsy report. I think it's not required. And so the first question is, why are we doing it? And then we can talk about the, how to do it and what is safe.
So it's always one second. It's always a dilemma. If we give chemotherapy and that doesn't work, we give 4 cycles of chemotherapy, which is a toxic therapy, and then we biopsy to diagnose. We always have to weigh.
No,
in
I
which
don't agree with
situation.
that. Dr. Sushmita, to create this dilemma, we are creating this dilemma. The world literature is very clear. that the biopsy is not required. And if you say that legally, how are we correct in giving chemotherapy without a, it's not required because the world literature shows so.
So let's
Yeah.
hear
Really
from
just-
Piotr as well as his
I
opinion.
fully support what was said. In Europe, nobody would do the biopsy in this case. You do the biopsy only when you have critical doubts. Okay? Like in this case, you mentioned, yes,
Yeah,
I
yes.
will do the biopsy.
Yes.
That was a different thing. That was the case when you had elevated doubts. If you put the you put the liver tumor, you put the.
Yes.
The liver, renal thing was not involved, so the thrombus was not starting there. So obviously there were doubts and biopsy was fully justified. But these are unusual situations. And if you do the biopsy, you always do it from the back, from the loin with true cut, in order to minimize the seeding and to get good, large cores of the tissue.
I'm a patient that will. Entire kidney being replaced with the renal tumor, very large, biopsy done, WT197. So now they told me that we can't give you a definite report, but it's probably not Wilms tumor. So, in all kinds of situations, as I said, in 2008, when I started with biopsies, 50% of my tumors were under WRT. I mean, we did not have any advantage of giving NSCT for Wilms tumor. And in our situation, I mean, like AIMS, we get the biopsy done very next morning. And, they said, yes, we have to lose about 5 days for the report.
So I think
So,
for the trainees and younger consultants, the question is very clear. If you have imaging typical of Wilms and the age group typical for Wilms, will you do a biopsy or not? I think Dr. Sandeep has quoted literature. So they will not do it. We also don't do it if it is very typical and the age group is typical. But there are conditions where you may do it. So I think we have a consensus on that. So we can move to the next question maybe. For the lack of
Just
time.
very last remark after the biopsy again. Expect only an answer, Wilms tumor or not. You can count on specifying the subtype because tumor is heterogeneous. Even if you have some anaplastic cells, that does not mean that this is diffuse anaplasia. So information is limited.
Yes. Agreed, sir. I think the literature says you're wrong 5% of the time if you don't do a biopsy and start the chemotherapy. So the literature says the figure is about 5%.
No,
If
but
I'm not, if
even
I'm,
that 5%, it is only 1%, which is a benign. So you will be
Yes,
wrong
yes.
because it is a rhabdoid tumor or a CCS,
Yeah.
but it's still a malignant.
still
tumor.
benign.
So I would like to highlight which we are missing the point, which is a question here, which Yan already mentioned. NACT or surgery first. So he mentioned a condition in this kind of a case where you would go for urgent surgery. And I don't know whether the people picked up. If the atrial thrombus is free and floating, there is a high risk of it getting detached and going and obstructing the right ventricular outflow or giving a large pulmonary embolus. So in that situation, it is an urgent kind of situation where we should go with the CTVS people and, at least remove that thrombus. Yes. If it's a fixed thrombus, which you mentioned,
Yes,
then obviously chemotherapy.
yes.
So,
Can
Archana
I-
ma'am, what
can I
kind of
interrupt?
chemotherapy you will suggest?
There is also rare report of Wilms tumor producing alpha beta protein. The Journal of Test Reports Pediatrics. only. So this is not, this is very rare, but sometimes Wilms tumor may produce alpha beta.
Well, that was normal, sir. In this case.
I don't know. But probably.
Yeah. Archana ma'am,
So what is your next question?
is it chemotherapy?
Chemotherapy.
What kind of chemotherapy, ma'am?
What chemotherapy, what duration?
Duration, yes.
When will you reevaluate?
I would definitely like to give chemotherapy upfront because of the reason that we don't want to delay giving chemotherapy because it may regress the thrombus itself. And if you have a free floating thrombus, it may give rise to so many complications. And we don't want to wait for so many days. So I would like to give a 3-drug treatment right up front for a Wilms tumor. And it definitely does take care of the thrombus itself in a large number of instances.
How many
I'm
weeks, ma'am?
sorry, I'm
How
sorry.
many?
Should be qualified first. It is free floating or it is attached to the IVC.
And can you really qualify on imaging? I don't think so.
Very difficult.
Very difficult on, Sandeep sir, can we really qualify it on imaging?
No,
I don't think so.
The problem is What protocol are you following?
Probably you have.
In the-
No, there's
You have to
very,
consider both CT reports and probably
Echo,
Doppler
ultrasound,
also at the same time.
Doppler and echo, everything was there.
Well,
We have Avinash or Archana, madam.
I'm sorry, once you have very high thrombus, you should avoid anthracyclines. So not three-track regimen, because later on you will probably have to use radiation therapy up to right atrium and heart. So avoid anthracyclines in such cases. Two-drug treatment would be enough. If it's not effective, you switch to VP16 carb. So that's the way to go, and avoid anthracyclines. Three-drug regimen is not justified here.
So Jan, again, there's a difference. The COG protocol mentions what Dr. Archana has mentioned, 3 drugs with anthracycline and for 6 weeks. The SIO protocol mentions 2 drugs for 4 weeks and reassess and then add VP16 carboplatin. But our experience has been with 3 drugs, including doxorubicin for a long series, large number of cases. We never had a problem. We usually reassess at 6 weeks, and then from there we take it on.
So we can listen.
COG protocol also says that if the thrombus is infrahepatic, below the hepatic veins, then you can go for upfront surgery. That is the standard COG protocol. But at least at our center, we have given neoadjuvant chemotherapy for all IVC thrombus, no matter what is the extent of it. So whether it is going above the hepatic veins or below the hepatic veins, we would give NACT for all. And in our experience, 25% of these cases are complete resolution of the thrombus. So they don't need any procedure for the K1.
So how to reevaluate the thrombus? Maybe we can have the radiologist comment.
So I just wanted to talk about protocol. Institutes don't follow as a routine policy a protocol. They individualize as per patients. Like in one patient, they would use COG protocol. That is what my.
Why do you think so?
That
Institutes,
it's
at
not
least
about
office-
your
at
institute
least-
only.
No.
I've seen many. It's not about Tata also, because you all have
We
a
also-
structure.
we
But
also
many
follow
places,
science,
many places there is sometimes they will use SIOP protocol, sometimes they will
No,
use
but
COG
institutional
protocol.
protocols are fixed, ma'am. It's not like we sometimes use COG or sometimes use SIOP.
I'm not saying you.
No, but their protocol is fixed, sir. They don't jump from COG to SIOP.
No,
Huh.
Dr. Yogesh, I think, no.
No, that is okay. That is okay.
Hybrid.
What you are saying is sometimes we use COG, sometimes SIOP. I don't think so. You can do
There
that.
are institutes. I am aware. That is why I am saying this. There are places where individual patient receives a protocol as per
Dr.
that
Sushmita,
patient. It's not
don't
a routine.
misunderstand. Our protocol is our protocol. And I say that it is a hybrid protocol, but we know what to do for which patient. It is not, we are following the philosophy of SIOP of giving neoadjuvant chemotherapy, but we have indications for that. So it is not that I choose. The indications are there for giving neoadjuvant chemotherapy, and indications are there for which we can go upfront for surgery also. So it's our protocol, which is, but the protocol chemotherapy, the format of chemotherapy is CO. The philosophy is there of SIOP that we don't go for upfront surgery for all patients. We don't do that because we waste OT time. So it is called HWT99 protocol, which has the format of the COG protocol, but we do the philosophy of, but it's not individualized. It is not, for this patient, I do.
Not in your
Chemotherapy
center.
No, chemotherapy protocol has to be fixed. If the institution is a large volume, if you're doing 2 cases in a year, then it doesn't matter.
I think that is so in most centers,
I
PGI,
think it
Nitin,
matters.
Sandeep,
I think it
you can have
matters.
comments on protocols for chemotherapy. I think it's fixed everywhere.
Protocol is not only for chemotherapy, it is about the treatment plan, the entire protocol.
We do a SIOP.
It's not only chemotherapy.
Okay.
So
Quick.
the protocol that AIMS is using cannot say that I'm using SAP or I'm using.
No, that's fine, sir. That's AIMS 91 protocol. That's fine. Yeah.
And there are a lot of institutions where if there is small venous tumor, they will go for COG way and maybe do the whole thing COG way itself. And there are others where
Agreed, sir.
they will find a large tumor. And I can tell you, SAP too, if I'm not wrong, they had said that given time that size should not decide
Matter.
whether you should do NACT or not do NACT. And they have proved in the data way back in seventies, that if you do not give NSCT, the chances of rupture are more even in a small tumor. So the tumor, of course, there are lots of studies and I can even quote those references where they have put it that more than 10 centimeter, and blah, 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 the chances of rupture are more. If I say hybrid in a way, so nothing wrong about it because in the chosen some good things from COG.
Agreed,
and some
agreed,
good
sir.
things from Tau. And I believe the way we are converging in 10 years, we will have one protocol really for all tumors, which will have the best of COG and best of SIOP eventually.
Yes. Priya, proceed.
So if you look, if
Thrombus, and nothing got up and said that thrombus was the atrial junction. So
No, 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 no. Sir, that was different case. That was germ cell tumor.
if you look what Americans are doing now, you will find out that they give preoperative chemotherapy in 25% of cases now. So that's a big group in CW, in COG, which is getting chemotherapy. This is one point. And the second point, in this early study by SIOP, which differentiated small and big tumors, again, there was a benefit of pretreating even small tumors.
I think we have 4 interesting cases. Let's go ahead with the case.
We will be able to take up 4.
Yeah,
We will have to limit them. I think 3 should be good
but
enough.
at least let's
Yeah.
move on in this case at least. Like we can see the CT after the Priya. So tell what chemotherapy was given and when was the CT done?
So moving on to the non-contrast sections, these are the axial sections. Here we can see that there is heterogeneously hypotense lesion in the right kidney with multiple small septae. There is no evidence of any calcification or fat density within the lesion. So to characterize it.
Can you please start the video again?
Yes, sir.
So this is the non-contrast axial
So
section.
this is the
Same patient.
CT scan of the patient post chemotherapy. So moving on to the non-contrast sections, these are the axial sections. Here we can see that there is heterogeneously hypotense lesion in the right kidney with multiple small septae. There is no evidence of any calcification or fat density within the lesion. So to characterize it further, we are moving on to the venous case image. In the venous case image, we can see that there is heterogeneous kind of enhancement present within the lesion, more in the septa, not much in the solid part. Then this tumor is seen extending along the right renal vein here, as we can see, and it is extending into the IVC. The IVC is distended and there is heterogeneous kind of enhancement which is present inside the IVC. So to compare, is present in the IVC. So tracing the IVC superiorly as we're coming, so this is the level of the hepatic vein ostia. So it is also involved, and moving further superiorly, we are able to see that this tumor is extending up to the level of RA, and posteriorly it is not separate from the wall of the RA. As far as the hepatic
Apart from this, what we were able to appreciate was that there was tumor thrombus which was reaching and involving the hepatic vein ostia also. Probably a delayed scan would have been much better because that would have been able to tell us the involvement of hepatic veins more. And apart from that, we were also able to appreciate that there was heterogeneous enhancement in the liver parenchyma, which was probably because of slow venous drainage or absent venous drainage. And apart from that, there was one more finding that the tumor thrombus was also extending into the initial or the proximal part of the left renal vein as well, which was not recorded in this video, I think.
Yeah, so we have a thrombus involving the ostia reaching till the atriocaval junction. So in the right atrium. So what do we want to give do next? Do we want to give more chemo or operate the child? If you want to operate the child, what should be the surgical approach? So those are the questions.
First of all, we have very nice response from the tumor, also from the thrombus. However, he's not going down. It's just smaller. Anyway, you will have the thrombus sticking to the vascular wall after chemotherapy. That's normal. I would still try to continue with chemotherapy. If the response were not so good, we would switch to VP carbo, but the response is good. I will just continue for next 4 weeks and then go for surgery.
Yeah.
So the surgical dilemmas faced by the surgeons, the approach should be taken in this case. It should be the tumor first or the thrombus first.
Next.
No. Just one word to add to my previous comment. If we prolong chemotherapy, we can find out later on that thrombus is tumor cell negative. We can also add some heparin to the treatment because the part of the thrombus which is composed only from the blood clots can regress easier. So some centers are giving also heparin. There is nothing to evidence-based to say that it is effective, but some believe in that. Regarding those questions, we are always trying to do everything at the same session. So thrombus with cardiovascular team, with cardiopulmonary bypass, because you have a thrombus in the right atrium. So you must be ready with the machine. No, even not ready. You have installed the machine. Yeah. And then you are safe.
I'd like to add in that when we do this kind of a case at BGI, so the cardiac surgeons always insist on a CT pulmonary angio. So I think that is an important part of the investigation to know that there should not be any thrombus which, breaks and goes into the pulmonary system. So that's an important take home, I think, which needs to be done in an area where this particular thrombus has come. And we also do both ends at the same time without the bypassing.
City was done, city was three, city scan was done before that, plus many times done during chemotherapy and before surgery. It was everything was done. My question is how is if tumor is responded, it becomes decrease in size, but thrombus is still persistent there. So we had to operate it. There is no dilemma on it. After 6 cycles, we plan to do for surgery. So we cardiac bypass. So we take it with our colleagues, colleagues and then we open it. We mobilize that tumor. Then how we approach to that problem? This is the most important. Initially, I thought I can take it by giving thyroid and it can come. But as radiologist said, there was not coding thrombus in the atrium. It was essentially a wall of right atrium. And during intraoperative, we need to cut the part of right atrium, part of some IVC. Later, it was very cardiac. So how we can approach
bypass before and do pulmonary artery clamping first, or we should try to remove by IVC. If it doesn't come, then we call cardiac surgeons.
I think
my question is
Jan answered it initially also. I think the patient has to be put on bypass first. So we usually do a big incision, sternotomy, going on in the abdomen, ready, and then put the patient on bypass, and then start mobilizing the tumor and the thrombus and everything. But patient has to be put on bypass first, because that is the safest way. Whether you clamp the pulmonary artery or not is something secondary. So the safest way is to put the patient on bypass, go ahead. That is what Jan mentioned.
No, I think, sir,
machine ready.
I think Dr. Basant is saying if it is floating, can you just open the IVC and pull it? Is it possible?
By this time, after giving chemotherapy, nothing is.
It would have fibrosed and stuck to the atrium. So I think you should always put the patient on a bypass, and that is much safer.
In such a high case, you cannot believe that you classically take off the cloth from down. So that's impossible.
Correct.
So you have to put a bypass, you have to remove the thrombus from right atrium and as low as possible, then open cava down and remove that. Please notice that at that time you have fully heparinized patient. So we finished the cardiac part of surgery, we still keep a bypass, and then we convert heparinization and resect a tumor. And it is not realistic that you will remove thrombus after chemotherapy in one piece. That's practically impossible. You will have to use a scissors, you have to go in sharp, because it will be sticking to the wall. And that's why my comment on anthracyclines, because later on you will most likely have to irradiate this patient because it will be R1 resection. And radiotherapy to the heart plus anthracycline to the heart is nothing good.
Is there, Ankur, may I?
Yeah, sure.
So there is one question which I always had and I've asked in a couple of meetings and did not get an answer. So when we put a patient on bypass, generally the trend of the cardiac surgeons is they use a cell saver. They kind of recirculate the blood which they're losing into the bypass machine, and so that there is less of blood loss. So having said that, in a situation of a malignancy, what is your experience, Dr. Yan, about using a cell saver? Should you use it? Should you not? Because the cardiac surgeons are quite adamant that it's their system. They use it commonly. So is there any oncological disadvantage to this thing, which is, it's not there in the literature?
Yes, this is a classical comment, but I would say simply we have no other choice. There's no other technical possibility. Of course, this blood is filtered, but you can say what is bigger, red blood cell or tumor cell? Like, no. So filtering, gene filtering is nothing, it's impossible.
Another thing, Jan, which I can comment here is that our cardiac surgeons have added that for most of these cases, they do a beating heart. So they will not paralyze, stop the heart, and they will make sure that there is no persistent foramen ovale or anything by intraoperative esophagogram, esophagus, this ultrasound. And then they would do a beating heart. So that increases the morbidity even further. So they don't have to stop the heart, they don't have to start the heart, it is beating heart and use the cell.
Yes, we are operating on beating heart when the thrombus is above liver and not in the heart. If they have to open the heart, even atrium, they have to stop it.
You can proceed. Yeah, proceed.
It's a NACT. The child underwent sternotomy plus right nephrorectomy, cavotomy, thrombectomy from the IVC and right atrium with pericardial patch repair of part of IVC and right atrium. This is the resected specimen with the thrombus.
So what was the response in the tumor post 6 cycles?
Ma'am, the size of the primary, it was the same, but the tumor thrombus in the IVC that shrunk as per the imaging. So
That CT we saw was after
That was
chemo.
after.
chemo.
Okay.
After chemo.
So the final HPE report was right-facing Wilms tumor with the blastomal component 15 to 20% with favorable histology.
Histology of the thrombus?
It showed tumor thrombus. Yes, sir.
In the thrombus, whatever they have sent labeled as thrombus, it has showed all the 3 components: the blastomal component, epithelial component in form of tubules, and the stromal component. So it is consistent with the.
In my experience, is very uncommon because most of it, at least in our setup, comes as fibrotic and no tumor thrombus. But we do get tumor positive thrombus also.
So if the thrombus, sir, was positive and we have done a cavectomy, and as Dr. Yan said, so it will become an R1 resection, not R0.
That's what he said.
Yes.
The RT.
So we have to keep that in mind. And the thrombus did not show the tumor, then can we call it R0? Dr. Yan, what's your thought about
This is always a great question. What we believe. Because if there is no tumor cells in a thrombus, that does not mean that there is no cells in tumor thrombus. That
Correct.
means that pathologists did not see them. And that means that either there is no tumor cells or there are tumor cells, but very few and were not discovered. So my opinion is to consider each thrombus tumor positive, and maybe only doses of radiation therapy could differ.
Yeah. So still treat it as microscopic residue positive. Yeah. Yes. Yes.
How many?
Now, is it still possible that cells are there and we have missed
We have
it?
taken only one section. In one section only, we saw these all the 3 components.
Okay. So we will go ahead thinking that it is microscopic residual positive and then treat it further. Okay. Next slide.
So on post-operative day 15, the child underwent post-operative Doppler study. We went ahead with a CT angio. Both of them showed thrombus in the inferior part of intrahepatic IVC.
Next slide.
So, sir, next question is how do we approach this new finding?
My question is that, sir, there was initial phase of Doppler in ultrasound, a post-operative period. It was absolutely all right. And during the thrombectomy, we have cleared the opposite renal vein, IPC, and atrium. At that time, there was flow in the Doppler. It was little bit slow, but there was flow. And initial 15 days, there was no thrombus at all. After 15 days, we found a small thrombus in the intrahepatic part of the body. Then what is it a tumor thrombus? It is a simple thrombus because of polarization of flow, or and how we can proceed it. But we are giving chemotherapy. Either we by intervention radiology or we should treat slow and
I think you can't, if I may, you cannot go back in and remove that, and it's in a location which cannot be removed. So you have to depend on radiotherapy. That's what I would think you need to do.
Yeah, check which stage and during that period. And what man recommend radiotherapist recommend within how many days radiotherapy is effective, how much load is required.
So now what do? We give chemo to the child once the child recovers and then give RT, or having seen the thrombus, give the RT first and then give the chemo. So yeah. So now there is an added element of this new thrombus in the infrahepatic IVC. If it was not there, within 2 weeks, we would have ideally given an RT and also given the chemo DD4A, we would have continued. But now with this thrombus, any changes in the management?
Results of RT are definitely poor if it is started after 10 days of surgery. So in that light, we have to take other decisions. Thrombus.
This is quite surprising that this thrombus exists infrahepatically after that extensive surgery. Prior to, maybe this is secondary thrombus in the place of stitching the vena cava. Question whether to go back there with surgery or maybe to do PET scanning and check whether it is positive or not, because it is unlikely that a surgeon who was able to remove that difficult thrombus with the tumor together missed the easiest part, in fact. So I think this is a secondary thrombus. I would check with PET-CT. If negative, I would accept the explanation that this is just, let's say, surgical thrombus, not oncological. And regarding postoperative treatment, I would go classically like with stage 3. So AV for 27 weeks, plus radiation therapy. Now we are not using even for stages 3 doxorubicin. There was a last study, 2001, which compared to doxa plus, doxa minus, and there were no big difference. Of course, this is a remake of previous study, but it was better done, and we eliminate doxorubicin in responsive tumors.
Also, ma'am, if you can highlight the side effects of cardiac radiation. Also, you will have to give liver radiation in the area of the liver because there is in the infrahepatic IVC. So, effects of cardiac radiation in children.
So it is proven that each gray of added dose to the heart increases 7% increase in cardiac events, and the increase in events increases with the passing time. So in children, we have to be extra careful while irradiating heart, and the doses are definitely lower as compared to the adults. The liver doses are also lesser, and what we usually do is around 10 gray to the flank, and then we boost the residual tumor to another 10 gray, around another 10 gray.
Because we're giving adriamycin. Yeah. So Sandeep sir, in your experience, like cardiac radiation plus adriamycin in follow-ups, long-term follow-ups, has it caused any cardiac dysfunction in these children?
Not really. So in our long-term follow-up of these kind of patients with IVC thrombus who received cardiac radiation, we have not seen the events of, but we don't know what is going to happen after 20, 30 years, because as the age advances, the incidence of cardiomyopathy also increases. So the cardiac dysfunction can be presenting late also, 15 years following the treatment with doxorubicin and radiotherapy also. So we have to really follow up for so we are doing that. We don't know. No, lesser. It's according to the protocol.
It is.
But
protocol.
total dose will be about 180
Cumulative
milligram
dose, yes.
per meter square, total doxorubicin dose. The cardiotoxicity usually is reported at around 350 milligram per meter square, but then it can happen earlier also. So we don't know.
Yes. My question to Archana ma'am, we should go for 3-drug regime chemotherapy or we need to change it? Yeah.
Yeah, not very sure about what was there in the initial thing. I was going to.
Follow-up plan, ma'am, question written there. After end of therapy. That is same. Ultrasound, X-rays. Okay. Priya, anything else?
Yes.